The Acoustic P10 system uses a transducer which generates images in a sector format. These are generated at a frame rate of up to 28 frames per second to produce a real-time grayscale image. Excellent imaging requires a number of attributes. These include high spatial resolution, excellent contrast resolution, good temporal resolution, and freedom from artifacts. I'd like to explore each of these attributes in a little bit more detail, as they are important in understanding the ultrasound image and in optimizing the ultrasound image. First, let's talk about resolution. The ultrasound image is a two-dimensional image, but there are three components to the resolution displayed in the image. The first is the axial resolution, the resolution along the axis of the ultrasound beam. The axial resolution determines the ability to differentiate as separate two objects that lie along the path of the ultrasound beam. In this example, the arrows point to two tiny bright echoes, which are microcalcifications in a breast cancer. These are identified as separate calcifications rather than merging together as a single echo as a result of the high axial resolution of the system used for this image. Axial resolution is related to the wavelength or frequency. As we can see in this graph, as the frequency increases from 1 megahertz to 15 megahertz, the wavelength associated with that frequency decreases. At 1 megahertz, the wavelength is approximately 1.5 millimeters, whereas at 10 megahertz, the wavelength is approximately 0.15 millimeters. Axial resolution is determined by the length of the ultrasound pulse, which typically consists of 2 to 3 wavelengths. Therefore, the pulses will become shorter as the frequency increases. The Acoustic P10 system operates at a frequency of between 2 and 4 megahertz. The wavelengths corresponding are between 0.4 and 0.8 millimeters. If we look at an ultrasound pulse as it passes between two nearby objects along the path of the ultrasound beam, we can see that if the pulse is longer than the distance between the objects, the echoes produced by these objects will merge and appear on the image as a single object rather than as two separate objects. If, on the other hand, a shorter pulse is used by using a higher frequency transducer, then this pulse will produce two discrete echoes. The axial resolution for the P10 system is estimated to be in the order of 1.1 to 2.5 millimeters. Another component of resolution is called a lateral resolution. This is the resolution in the plane perpendicular to the ultrasound beam and is indicated by the L in this image. Notice that the lateral resolution changes with position from the transducer. The lateral resolution is poor near the transducer, narrows to a point indicated by the parallel lines and arrows, and then diverges again deep to this point. Lateral resolution defines the ability to differentiate objects that lie side by side in the plane perpendicular to the direction of the ultrasound beam. Again, we see two calcifications lying side by side in these images, which are defined by the lateral resolution of the ultrasound device. A third component of resolution is the elevation resolution. This is determined by the thickness of the ultrasound slice. This cannot be varied by the user. Axial resolution then is fixed and is determined by the transducer and the transducer frequency, higher frequencies producing higher axial resolution. In the P10, lateral resolution is determined by the exam type selected. It is internally focused by the software and cannot be controlled individually by the user except by changing the exam type. For example, an abdominal exam evaluating deeper structures will set the lateral resolution or the focus for a greater depth than for a superficial examination. Elevation resolution, which determines the thickness of the ultrasound slice, is fixed and is determined in the design of the transducer. Unlike CT and MR, in which the image is derived from measurements of physical properties of tissues, ultrasound is quite different. Ultrasound basically is based on a number of assumptions about how the acoustical energy interacts with tissue. These assumptions are important because frequently they are not fully met in the generation of the image, and this can result in artifacts which may be confusing or misleading. The first assumption is that the ultrasound beam is narrow and uniform in width. As we saw in the preceding slides, the lateral resolution in fact is not uniform. It may be quite large or poor near the transducer and far away from the transducer, and is optimal only in the focal zone. In addition, most transducers produce energy which extends outside the primary beam. In this case, a sclerin photograph shows a beam profile which narrows to a focal point, as well as an additional ultrasound field which extends to the side, indicated by the arrow. This is an area of relatively high acoustical energy, which may interact with strong reflectors and produce important artifacts. If, for example, a strong reflector, such as gas or bone, lies outside the primary beam and encounters a side lobe of high energy from the transducer, the echo from that interface may return to the transducer. The machine assumes that the echo is coming from along the beam path and therefore displays the echo in an incorrect location within the image. These are called side lobe artifacts and may be quite conspicuous. The arrow here points to an artifact projected over the distended bladder in a pelvic ultrasound. This side lobe results from the interaction of the acoustic field of the transducer off-axis with gas in adjacent bowel within the female pelvis. Side lobe artifacts are important and may particularly pose a problem in the examination of areas in which both gas and fluid are present. These are both conditions that exist in the evaluation of ascites and pleural effusions, which are common bedside procedures performed with handheld ultrasound devices. Here, for example, is a view of the abdomen in a patient with ascites. The arrows point to two linear echoes extending to either side of a loop of bowel. These, in fact, are artifactual rather than real and are side lobe artifacts. By slightly changing the angle and position of the transducer, these artifacts disappear. Another assumption involved in ultrasound is that the ultrasound beam travels directly to and from the echo-producing interfaces. This then brings us to a discussion of what kinds of structures reflect sound and serve as acoustical interfaces. There are two types of reflectors: diffuse scattering reflectors and large mirror-like or specular reflectors. Diffuse reflectors arise from very small interfaces, smaller than the wavelength of the ultrasound used to produce the image. When ultrasound interacts with these small reflectors, the sound is scattered in all directions, a small amount of which may return to the transducer to produce the image. Diffuse reflectors produce the characteristic echo pattern associated with the parenchyma of organs such as the liver and spleen, kidneys, and uterus. Large flat surfaces act more like mirrors. This view shows the liver with the bright curvilinear echo of the diaphragm along the back of the image. Notice that a portion of the diaphragm is quite bright and well defined, but as we go to the left side of the image, we see that the diaphragm fades from view. This is because the portion of the diaphragm which is nearly perpendicular to the direction of sound reflects sound directly back to the transducer, much as a mirror would. whereas sound striking the portion of the diaphragm to the left reflects off away from the transducer, and as a result that portion of the diaphragm is not displayed.